Hello, everyone. Today we're going to be talking about endocrine disorders. This is Module 12 and the last module of the content for this course. So, yay! Okay, pause to read this next slide for the objectives. But the only thing I want to say is that you should be already familiar with several conditions like diabetes type 1 and type 2 before we go into these new we're building upon that knowledge that you should already have about the differences between a type 1 diabetic and a type 2 diabetic and the management of their care. So if you have not, if you do not feel comfortable with those two concepts, I suggest you go back and review your med-surg notes and reading content to become more familiar with those things and those concepts and the management of their care, because we're going to be building upon those. Okay, let's get started. The first thing that we're going to be talking about is DKA, or diabetic ketoacidosis. So when we talk about diabetic ketoacidosis, or DKA, it's helpful to think of it as a state where the body is lacking insulin so severely that it starts breaking down fats for energy instead of glucose. Insulin is crucial for moving glucose from the bloodstream into the cells, where the actual cells can actually use it, break it down for energy. Without enough insulin, glucose builds up in the bloodstream within the body of the patient, but the cells remain starved for energy. So let's break down some of the primary causes of DKA, starting with insufficient insulin. This can happen for several reasons. Sometimes a patient with diabetes might miss insulin doses, which could be due to a limited access of medication, lack of education, or even psychological factors like fear of hypoglycemia. For others, DKA might be the first sign of diabetes, often in young adults or children with new onset type 1, as they have virtually no insulin production. Now let's consider illness or infection. When the body is under stress from conditions like an infection or surgery or illness, it releases stress hormones such as like cortisol and epinephrine. These hormones make blood sugar levels rise as the body tries to mobilize more energy to fight the illness. However, in people with diabetes, this response increases blood glucose without enough insulin to balance it out, which can lead to DKA. Physical or emotional stress can similarly increase blood sugar levels. Stress doesn't just mean intense situations like moving to a new place or like a nursing school exam or like a job change. They can all elevate glucose levels though. Finally, certain medications, especially those corticosteroids like prednisone, and some diuretics can lead to high blood sugar as a side effect. So, and that would then push the patient into DKA if they're already in insulin deficiency. So you need to be able to understand these triggers so that you can help recognize early warning signs and educate your patients on managing stressors to reduce their risk of having or developing DKA. So diabetic ketoacidosis is a combination of three interconnected physiological issues: hyperglycemia, or high blood sugar, ketosis, and metabolic acidosis. Okay, so let's go through each of these to understand how they impact the body and contribute to DKA. So with hyperglycemia, that's the first major disturbance in DKA. Hyperglycemia simply means high blood sugar. In DKA, glucose levels can often exceed 250 milligrams per deciliter. Because there isn't enough insulin to move the glucose into the cell, the blood sugar builds up in the bloodstream. Imagine the cells, basically just imagine your cells in your body crying out for energy, but like they're starved. They want stuff. They can see the food, but it just can't come to them, okay? This is kind of like being a baby. Very much. Like they can't get it into their body. They need help, right? So your cells can't get the energy inside themselves, obviously. And so they need some help. And the help is insulin. Insulin is what brings it in, okay? So despite you have a high amount of glucose in the blood, you just can't get it into the cells, okay? So that's where the hyperglycemia comes from. And that forces the body to look elsewhere for energy, okay? So now the second disturbance is ketosis. When the body senses it's not getting enough energy from glucose, it turns to fat as an alternative fuel. As the liver breaks down the fats, it produces ketone bodies, okay? Normally, these ketones are used in small amounts as backup energy. But in DKA, ketones accumulate rapidly, reaching high levels that create that imbalance. For instance, you might see acetone, a type of ketone, causing a fruity smell on the patient's breath, which is one of those unique signs of DKA. The third disturbance that is a hallmark sign of DKA is metabolic acidosis. This occurs as ketones accumulate in the bloodstream. Ketones are acidic, and their buildup lowers the body's pH, leading to acidosis. In healthy individuals, the blood pH is tightly regulated between 7.35 and 7.45. But in DKA, this balance is disrupted, and the pH can drop below 7.3, making the blood more acidic. This acidosis affects multiple organs and can cause symptoms like nausea, vomiting, Kussmaul respirations. And just as a reminder, Kussmaul respirations, those are a form of deep, labored breathing. And all that occurs as the body is trying to expel and get rid of the excess carbon dioxide to raise the pH, okay? So each of these physiological changes are interconnected. They don't happen without the other one. They're all happening at the same time. Hyperglycemia leads to ketosis, and ketosis leads to acidosis. Together, they create that dangerous condition that we call DKA, which requires urgent and immediate intervention. When assessing a patient with DKA, it's important to be able to recognize the typical clinical signs and understand the laboratory findings that confirm the diagnosis. Okay, so a primary sign of DKA is dehydration. This is hallmark. One of the biggest things I want when you guys say DKA, I want you to immediately think they're dehydrated, okay? This happens not just they have high blood sugar and acidosis and ketones. They are also, I just want you to immediately say dehydrated, okay? So this happens because the hyperglycemia causes an osmotic diuresis, and that is where high blood sugar draws the water into the urine, okay? This is why patients in DKA often present with polyuria, which is frequent urination. Also, they come in and they might be complaining of just severe thirst, and there are also signs of dehydration like dry mucous membranes and poor skin turgor. So the next big sign is, but it's not necessarily an early sign, but it is a sign, is altered mental status. That can result in a range from mild confusion to full-blown unconsciousness in severe cases. The brain is very sensitive to pH and glucose changes, okay? So the acid-base imbalance when a patient has DKA can significantly impact the cognitive function. Patients also experience nausea and vomiting, a response to that metabolic acidosis that is created by the high blood sugar and the ketones, right? So the body attempts to rid itself of those acids through multiple routes. One of them is vomiting, okay? And that's its way of compensating. The symptoms can further dehydrate the patient, making the dehydration worse. Okay, so some of the laboratory findings that you will have ordered on your patients with DKA, okay? So key markers include extremely high glucose levels, like typically over 250. But if we're getting in that 800 range and above, I want you to hold the phone on saying that this is DKA. More on that in a second. DKA is typically like 250, 500, maybe even 600. But once we start crawling up there in the upper, like closing in on 1,000, it's probably something else, even though it gets mislabeled at times. But so extremely high blood glucose level, typically over 250. Blood gases are another order that might come through. And so those often reveal low bicarb levels, typically under 18 milliequivalents per liter. And that happens as the body has used up all the available bicarbonate in an attempt to neutralize the acids in that buffer system, okay? So what little bicarbonate that you have in your system, when you become acidotic, your body is trying to use that to maintain that pH. But you don't have enough to truly maintain it, okay? So the pH of the blood is probably going to drop below 7.3, indicating that acidosis. And so together, these signs and lab findings are going to guide you to a prompt diagnosis and help prioritize the treatments for DKA to stabilize that patient and provide a metabolic balance. So treating DKA involves multiple steps aimed at correcting the dehydration, correcting the hyperglycemia, and the electrolyte imbalance, okay? Each of these areas are super important, critical, actually, for stabilizing the patient and stopping the DKA cycle. The first step is fluid replacement. I know you're thinking, but they have high blood glucose and acidosis. Don't we want to fix those? Yes, we do, but we need to get fluids on these patients first, okay? Most patients with DKA are severely dehydrated. We've already been over this due to that polyuria, where the body loses significant amounts of water as it tries to clear the excess glucose. Fluid replacement helps replenish this lost volume. It also helps improve circulation, and it begins to dilute that high glucose levels in the blood. Okay, so it's diluting it so that when we measure it, we don't have that high concentration. So in a way, it does lower the glucose, if that makes sense, by diluting the blood. Typically, treatment starts with just normal saline, okay? You might get orders for several liters of fluid depending on the size of the patient, but just boluses, just pour it in them basically, okay? So we're going to be giving that IV. As hydration improves, the blood glucose levels start to go down. The fluid type might be adjusted to actually include dextrose, because we'll get into it in a second, but as we're giving insulin, we might have a rebound and they might become hypoglycemic. So we might actually start adding a little D5W, like some little bit of glucose to the IV solution because we need to be correcting the acidosis. We'll go over it in a second. But anyways, just know that that's normal. Initially, just normal saline, and then we might add just a little bit of sugar to the fluid so that we don't become hypoglycemic. Okay, so next thing we're going to talk about is insulin therapy. This is probably the number one thing you think of when you think of somebody in DKA. So insulin is that super important thing that allows the glucose to enter the cells, which helps decrease blood glucose levels and stops the production of ketones. Insulin is typically given IV in an emergency DKA setting because IV administration acts faster than that sub-Q injection. And you will literally just take it and IV push it straight into the IV and follow it up with a flush, okay? As glucose levels drop, the production of ketones is going to decrease because now your body, once you get insulin into your body, your cells will then be able to start getting that sugar that's in an energy that's in the blood into the cells so that they can use it. So they're not going to be as hungry. So the body's like, oh, we don't have to break down fat anymore since we have sugar available now. But what the body doesn't realize is we always had sugar available. What we didn't have is the insulin to get the sugar into the cells, right? So as we give insulin, the glucose levels are going to drop. And so we're going to not have as many ketones because we're not breaking down the fats, right? So it's going to gradually correct that acidosis because we're not going to have as many ketones, so we won't be as acidotic. So as a nurse, you're going to carefully monitor the blood glucose, and you're going to titrate that insulin dose to maintain a gradual reduction in the blood sugar to avoid a sudden drop, which could lead to complications like cerebral edema. We never want to drop somebody's sugar really rapidly. We're going to have a slow decline. So this is why they're going to get admitted. We're not just going to correct it in the ER and send them home. We're going to get admitted. We're going to monitor them for a day or 2 or 3. They're probably going to go to the ICU or IMU depending on the policy of your facility and how bad their acidosis is. But we're going to slowly, gradually lower it over time. So the medications used in DKA management, we already kind of talked about insulin, but let's go over it again. Okay. So we use it because it quickly reduces the blood glucose versus other forms of regular insulin is typically what we use in the IV push setting, because it's going to quickly reduce like that blood glucose and it's going to halt that ketone production, like what I just said. Okay, so just as a reminder, by lowering that glucose level and reducing that ketone production, insulin is going to help address both the hyperglycemia and the acidosis. That IV insulin is typically started as a continuous drip. After that IV push, I mean, you could go straight for a drip too. It just depends on the orders. And then we're going to closely monitor and adjustments to the rate of the insulin based on the patient's blood glucose levels. So the nurses are going to check glucose levels at least every hour and adjust the insulin infusions to maintain safe and gradual glucose reduction. Now, here's a question about delegation. Can you delegate the insulin checks to somebody else, like blood glucose sticks? Yes. But you better follow up immediately. And part of your order needs to be as soon as you get it, come to me. Don't wait another hour before you report it to me, kind of thing. So you can delegate for somebody else to do the glucose check, but you are responsible for getting that information very quickly and making a determination if you need to titrate the insulin or not. Okay, so next, we are going to have to actually give potassium replacement. So if you remember, insulin helps push sugar into the cells, but what it also does is it grabs potassium and it shoves it into the cell as well. So if we're giving a whole bunch of insulin to correct the hyperglycemia, we're also going to be shoving all this potassium into the cells, and it's going to drop the patient's potassium, okay? So before you start insulin, especially an insulin drip, you might want to check to make sure you at least have a normal potassium level. If your potassium is already low, for whatever reason, we might want to hold a second and make sure that we have potassium on board before we start giving this insulin, because it might drop too dangerously low. Okay. So that's one of those things that we want to check before we give the med. Okay. Before we give insulin, we want to make sure potassium levels are at least within normal range. Okay. So, and if that potassium does drop too low, it's going to impair cardiac function. Your heart muscle is so sensitive to that potassium level. Okay. We don't want to stop the heart and cause arrhythmias because we didn't address the potassium, knowing that the insulin is going to cause that potassium to lower. Okay. So we're going to be also checking that potassium frequently. And if necessary, we're going to give fluids with potassium in it. Okay. We can give oral potassium, but it's not fast enough. So we'll typically do fluids that have a little bit of potassium in it. So bicarb is also used in DKA to treat patients. Okay. But it's not always given. Okay. And that's a change more recently. It used to be given all the time, but it's very specific cases. So if the patient's blood pH is extremely low, like typically below 7.0, bicarb might be administered to help raise the pH and temporarily relieve severe acidosis. However, routine bicarb use in DKA is not recommended because it can have side effects like causing shifts in potassium and worsening acidosis in the long term. Bicarb therapy is carefully monitored and reserved for the most severe cases, or just people that are happy-go-lucky and order it. But anyways, always just question it, like, is it needed? And if you have a severe case of DKA, it probably is indicated, okay? So these are some of the medications that are part of a balancing out DKA treatment, but it does require you as the nurse to be vigilant about assessing your patient and monitoring those lab values. You need to be making sure that those lab draws are happening when they're ordered so that we have serial numbers to truly check trends. If they're going up, they're going down, they're staying the same, whatever the case may be, okay? Overall, this approach to treating DKA is a balancing act, and it's going to require, like I said, monitoring and adjustments in both the fluid, insulin, and electrolyte levels to stabilize the patient effectively. So, kind of talked about some of these, but let's go a little bit more and review some key lab tests and how they help us understand the severity of DKA and guide our treatment. So serum osmolality. Have you ever talked about this before? Okay, what it does is it measures the concentration of solutes like glucose in the blood. So in DKA, serum osmolality is typically high because of the hyperglycemia, which increases the amount of solute, in this case glucose, in the blood. High serum osmolality can lead to dehydration as water moves out of cells and into the bloodstream, okay? Reverse, if you have low serum osmolality, you're going to have more third spacing, and it's going to be pulling the fluid out of your vasculature system into your interstitial spaces and causing like edema and stuff. So high serum osmolality is going to pull more fluid into the bloodstream, and then you're going to then pee it out, which is what causes the dehydration, okay? So we need to be monitoring serum osmolality because that's going to help us assess the hydration status and monitor for potential complications like cerebral edema, especially when we're lowering the blood glucose. So anion gap is another important lab finding in DKA. It measures the difference between positively and negatively charged electrolytes in the blood. A high gap indicates that there is an excess of unmeasured acids, often ketones, contributing to metabolic acidosis. In DKA, the anion gap is usually elevated due to the ketone buildup. Monitoring this gap is important to track the progress of acidosis. As treatment continues, the gap should gradually decrease. So if you've been in the beginning, your first set of labs, you're going to have a high anion gap, okay? So as you're treating them after you've been doing things for a day or two, that should normalize. It should lower. If it's not lowering, then they're still acidotic, and you need to ask yourself why, okay? Next, pH. I think you already know this, but pH provides that direct measurement of the blood's acidity. In DKA, the pH is low, often less than 7.3. Okay, again, it's due to those high levels of acidic ketones. Low pH confirms metabolic acidosis, and it's used to assess the severity of the condition. Regular pH measurements can help determine if the acidosis is improving with the treatment. And then again, last, we're going to talk about serum glucose. Obviously, you'd be monitoring this in somebody in DKA. So if serum glucose is consistently high in DKA, typically it's over 250, like I said before. Okay, so when it's high, we're going to be monitoring those glucose levels very frequently, every hour. And in the beginning, like if you're giving IV insulin to correct, in the beginning, you might be doing blood glucose checks every 15 minutes for an hour or 2 or 3, depending on. When you first start an insulin drip, you're going to be monitoring probably every 30 minutes minimum. It just depends on your policy, how often you're checking. And then while somebody's on an insulin drip, it might be every hour or 2 hours, depending on what stage they're in and if they've, if you've been able to manage and not mellow out, but basically, what's the word I'm looking for? Equilibrium, basically the acidosis, and return it more to baseline. So these are the lab tests that are essential tools, okay? These things are the ones you need to understand what they mean, and if it's high or if it's low, what that means. Is it making are things getting worse, or is treatment being successful, okay? So now let's talk about HHS, or hyperosmolar hyperglycemic syndrome. This is what gets confused for DKA a lot. Okay, hyperosmolar hyperglycemic syndrome, or HHS, is another serious complication of diabetes, but this one is the one that primarily affects people with type 2, okay? Unlike DKA, HHS involves extreme hyperglycemia without significant ketone production. Okay, so there's no acidosis in this. So these patients could come in with a blood glucose of 842 and they're not acidotic. And you're like, what? Is the lab results, are these correct? Yes, they are. Okay. The difference occurs because people with type 2 diabetes often produce just enough insulin to prevent ketone formation, but not enough to control the blood sugar. Okay, so they produce enough insulin to get just enough sugar into the cells so that they're not starved, which triggers your body to break down the fat, right? Just enough, but they're still consuming lots of sugars and they're not able to store it effectively. They have all sorts of metabolic issues, most likely. And so their blood glucose is just extreme, okay? In HHS, blood glucose levels can rise extremely high, like I just said, often above 600, okay? This high glucose concentration creates osmotic diuresis, okay, where the excess glucose pulls the water out of the body and into the urine. So first it's going to pull it out of the cells into the vasculature system, and then filter it out through the kidneys into the urine to get it out, because it wants, your body's like, we should not have this high of glucose in our system. We need to get rid of it. So it's going to make you, urinate it out. Okay, so this is going to lead to a profound dehydration, as the patient is going to lose very large volumes of water and electrolytes. The dehydration in HHS is often way more severe than in DKA, and it can result in very high serum osmolality, okay? So one of the hallmark signs of HHS is altered mental status, with patients experiencing confusion, lethargy, or even a coma in some severe cases. The altered mental state occurs due to the dehydration and the high serum osmolality, okay? So it's basically shrinking and shriveling up your brain. If you think about it, it's pulling all of the water out of everything, okay? And then it's causing all these electrolyte imbalances, because if you think about it, the fluid needs to be equal in the vasculature and in the tissues. And if you're pulling all the fluid on one side, now you've diluted the stuff out here, and the stuff inside the cells is a higher concentration. You have all sorts of issues, okay? If that can make sense. Okay, so this is especially dangerous in elderly patients who are more susceptible to HHS. So to summarize, HHS is characterized by that severe hyperglycemia, often above 600, severe dehydration, and altered mental status, but it lacks acidosis that is found in DKA. So if you recognize this distinct picture, like the distinct between HHS and DKA, it's going to help guide treatment and know what to do, because there's no acidosis in this, and we need to really push fluids, right? Fluids. So now let's flip the script, and we've been talking about hyperglycemia. So now let's talk about hypoglycemia, or low blood sugar, okay? So it is defined as blood glucose levels below 70. Now, this could change based off of what textbook you use, what source you're going with, okay? But if I were to give you a test question, I'm going to make it obvious if it's hypoglycemia. Like, you're going to get like a 52 kind of thing, like it's not going to be on the border. So this condition can be quite dangerous because glucose is the brain's primary source of energy. When blood glucose levels drop too low, it can lead to symptoms that affect the brain, like confusion, dizziness, or even loss of consciousness. So several factors can cause hypoglycemia. The most common one is excess insulin, which can happen if a patient takes too much insulin or if they're taking oral diabetic medications that increase insulin production. Another cause is missed meals or insufficient carbohydrate intake after taking insulin or diabetic medications. So increased physical activity can also lead to hypoglycemia, especially if the patient hasn't adjusted their insulin dose or consumed extra carbohydrates before they exercise. Lastly, alcohol intake can also lead to hypoglycemia, particularly if you consume the alcohol without food, because alcohol affects the liver's ability to release glucose. So understanding this can help in preventing hyperglycemia. So educating your patients on these things and how they need to be taking their insulin. Don't miss meals. They need to, if they're going to be doing a marathon, they should be adjusting and talking to their diabetic educator about how they can adjust, how they can make sure they're having enough carbs for what they're taking. Hopefully they have a continuous glucose monitor on them. But dangerously low glucose can happen. I will also tell you, while we're here, this has nothing to do with diabetes. Well, it might. I mean, the patient might have diabetes, but a lot of times hypoglycemia is misdiagnosed or misthought of as a stroke, especially to lay people. I will tell you that a lot of law enforcement agencies have trained law enforcement officers to do basic neuro checks and smell the breath of people to see if they are, if they have like a ketone breath. Because if somebody is acting like maybe they're intoxicated driving down the road, it might actually be because they have low blood sugar. And so these are some of the things that they have to kind of unfortunately assess without the full medical knowledge and background to try to do the assessments. But they do because, and it's happened a lot, where somebody was suspected of drunk driving and it was really because their blood sugar was low. Because like I said, low blood sugar really affects the brain. And so it can come off like you're drunk. It can come off like you're having a stroke. So when somebody first comes into the ER with stroke-like symptoms, one of the first things we're going to check is blood glucose level, like real quick, just to make sure it's within normal range. Okay. Because if it's 38, obviously we need to give dextrose and it's probably not a stroke, but I mean, it still could be, but there's that. Okay. So clinical manifestations and pathology of hypoglycemia. I kind of jumped the gun, but okay, whatever. The symptoms of hypoglycemia are divided into two main categories, adrenergic and neuroglycopenic. I have to say that slow. Okay, adrenergic symptoms are related to the body's fight or flight response, which is triggered by the blood glucose drops. When the blood glucose drops. When glucose levels go down or they fall, the body releases adrenaline, a hormone that causes symptoms like tremors, sweating, and tachycardia, fast heart rate. These symptoms are early warning signs that help alert the individual that their blood sugar is going lower or is low. If blood glucose continues to drop, neuroglycopenic symptoms appear, which result from insufficient glucose to the brain. This is the stuff I was just talking to you about on the last slide. The brain relies on that glucose as its main energy source. So when the glucose is too low, cognitive functions are impaired. Parents may experience confusion, dizziness, blurred vision, difficulty concentrating, slurred speech. Sounds kind of like maybe somebody that might be having a stroke or maybe somebody that has intoxicated with alcohol. Yeah. So in severe hypoglycemia, patients can experience seizures or even lose consciousness if glucose levels are not quickly restored. These symptoms require immediate intervention to prevent permanent brain damage. Recognizing these symptoms and understanding their cause is crucial for effective and timely hypoglycemic management. So how do we treat hypoglycemia? Glucose. Okay, so treatment for it involves rapidly restoring blood glucose levels. So we can do this several different methods depending on how severe it is. Okay, so for mild to moderate hypoglycemia, oral glucose is the first line treatment. This can be 15 to 20 grams of fast-acting carbohydrates, for an example, like 4 ounces of juice, regular soda, glucose tablets, or candy. The 15-15 rule is commonly used. Get 15 grams of carbs, wait 15 minutes, recheck the blood glucose. If it remains low, repeat it again until you get normal. In the case where the hypoglycemia is severe or the patient is unconscious and unable to take anything by mouth, please don't put anything in their mouth. They can aspirate. So at that point, we're going to do IV dextrose, D50. And D50 is 50% glucose solution given directly into the vein, which is going to quickly raise the blood glucose levels, and it's used in emergency treatment. For patients without IV access, a glucagon injection can be administered sub-Q or IM. Glucagon is a hormone that stimulates the liver to release stored glucose, so that will raise the blood sugar levels for time being. Family members or caregivers of diabetic patients are often trained to administer glucagon, especially if the patient is at high risk for severe hypoglycemia. And this might be something that you will be educating your patients and families on how to administer. So, education is one of the most powerful tools for helping patients with diabetes manage their conditions effectively. For both type 1 and type 2, knowing how to monitor blood glucose, manage the medications, and make lifestyle adjustments can prevent complications and improve the quality of life. Blood glucose monitoring is essential. I think we all know that, right? So patients need to understand when and how often to check their levels. For instance, people on insulin might need to check before meals and at bedtime. That's really common, right? While others may check less frequently. Proper techniques, such as using a clean, dry finger and enough blood on the test strip, ensures the accurate readings. Medication management is also key, as patients need to understand their insulin, why it's being given, okay? Use simple people speak. Don't use big fancy words. They need to understand that their cells are starving, even though they have sugar in there. Insulin is the key to getting it in the cell, kind of thing. You can even use like your cells like a baby, starve for food. The baby can't this is like newborn baby. The baby can't grab the food and put it in their mouth. So you are, as the caregiver, insulin, getting the food, the sugar in the blood, and putting it in the baby's mouth, the cell, kind of thing. Like it needs help, okay? Figure out a way to explain it, make it easy for them to understand, okay? So they know why it's important, okay? Patients on insulin need to know about the different insulin types too, because there's a bunch, right? Like, what's the difference between rapid acting, long acting, and how they work to manage blood glucose levels? Okay. On this note, insulin can be super expensive. So you should be asking if they have not just if they have insurance, but if they even have, because even with insurance, it can be very expensive. If they have the funds necessary to pay for to pay for their meds. If they don't, you should be working with their physician and advocating to find something that is more reasonably priced, okay? And it might even be getting case management, social workers involved to see if they're eligible for a different insurance option or something. If you're like if you live in Harris County, you can get the Gold Card. And the Gold Card, they have pharmacies through Harris Health, and it can make things cheaper. And it might be cheaper than their option for insulin. So as a nurse, you should be advocating for your patients, and you should be asking those questions to help them. We're looking at them holistically, right? So the last thing I'm going to talk about is lifestyle modifications. Obviously, a balanced diet, regular exercise, and stress management are going to all contribute to good glucose control. So as a nurse, you need to be educating your patients on these different things, including like how to count carbohydrates, adjusting the meals for activity levels, and incorporating those relaxation techniques or some things to like calm them down so they don't have constant levels of stress, so that they have optimal glucose levels. Okay, now let's switch the topic again. SIADH and DI. Hopefully, this isn't the first time you're being exposed to this content, but if it is, let's go down this journey together. Okay, so you need to be able to distinctly tell the difference between SIADH and DI. SIADH is syndrome of inappropriate antidiuretic hormone, and DI is diabetes insipidus. Do not think that diabetes insipidus is like diabetes type 1 or 2, okay? It's not. So these are two distinct things, and I kind of have a screen where they're kind of comparing the two, okay? So SIADH, or syndrome of inappropriate antidiuretic hormone, this condition involves excess release of ADH, which causes the kidneys to retain water. This excess water dilutes sodium in the blood, so you have more fluid in the system because the kidneys aren't excreting as much fluid. So now the blood is more dilute, so your sodium levels are going to be lower, okay? So patients with SIADH may present with symptoms like headache, confusion, weakness, and even seizures due to that low sodium. Water retention can cause the patients to gain weight without visible edema because it's primarily retained inside the cells. In contrast, diabetes insipidus occurs when there's either an ADH deficiency or a resistance of the kidneys to ADH. When enough ADH, without enough ADH, the kidneys can't retain the water effectively, leading to excessive water loss. Patients with DI experience polyuria, which is excessive urination, and polydipsia, which is excessive thirst. They're also at risk for hypernatremia, which is high sodium levels, because the body loses water but retains the sodium. So it's not as much fluid in the tubes, but the sodium remains the same. So it's a higher concentration, so higher sodium levels, okay? Symptoms in DI include dry mouth, fatigue, signs of dehydration, as well as confusion or lethargy in some of those severe cases. Okay, so SIADH, we are keeping water, okay? So we have a lower sodium, okay? DI, we're getting rid of water, and so we have a higher sodium, okay? I hope that makes sense. And some people say diabetes insipidus, sip, like you're sipping on water. This is the one where you constantly want to sip on water because you're constantly peeing it out. That's one way to remember it. But yeah. So lab findings. Okay. So in SIADH, we typically see low serum sodium, hyponatremia, and low serum osmolarity. Okay. So when you don't have a lot of electrolytes in there, so the osmolality is going to be lower, right? Okay. Because the blood is diluted, okay, because we retained water, right? Okay, hope you're with me. Okay, so since the kidneys are reabsorbing the water, urine becomes concentrated, resulting in high urine osmolality. Since the kidneys aren't, okay, where did that, I'm sorry if I said that wrong. Let's start over again, okay? SIADH, low serum sodium, low serum osmolality, because we are retaining water, so it's more dilute. We're keeping the water in, okay? So high urine osmolarity and high urine specific gravity, okay? So what urine does come out is concentrated because we're keeping it, if that makes sense. Okay, so we're keeping the fluid. But in diabetes insipidus, there's high serum sodium and high serum osmolality, right? Because we're just getting rid of all this fluid. So what the fluid is leaving us is going to be concentrated. So the urine output is diluted. I hope I'm saying this right. Okay, so the urine in diabetes insipidus is diluted. So if you see the screen, the blue means dilution, the red means highly concentrated. So serum is blood, urine is urine. Okay, so in DI, the serum, the blood, has a high concentration. Okay, so it is not diluted, it is concentrated. The urine, because we're peeing everything out, is, what is it? If you said diluted, you're right. Okay, so low urine osmolality, low urine specific gravity, because the fluid is in the urine, not in the system. I hope that helps, and I hope I didn't confuse you. Okay, switching to another topic, myxedema and myxedema coma. Okay, so myxedema represents a severe advanced form of hypothyroidism, okay? In myxedema, the body lacks enough thyroid hormone to support normal metabolic processes, which leads to extreme slowing down of bodily functions. The myxedema coma is a life-threatening complication of untreated hypothyroidism, characterized by severely low body temperature, hypothermia, low blood pressure, hypotension, and slow heart rate, bradycardia, and respiratory depression. Everything's low. Everything's slow. Nothing, because the thyroid is like your energy source, right? Not your only energy source, but right, it's your body's ability to have metabolic functions and everything. And so if you don't have thyroid and it's working really low, everything is low and slow. Patients may present with swelling of the skin and tissues, particularly in the face and limbs. This swelling, or myxedema, is due to the accumulation of mucopolysaccharides, which retain water. Symptoms often include fatigue, cold intolerance, dry skin, and confusion. In myxedema coma, a critical emergency, so the coma is the emergency, rapid intervention is required. Treatment often includes IV thyroid hormone replacement, warming measures, and respiratory support to stabilize the patient. This condition is important, and it highlights the importance of monitoring and managing hypothyroidism in patients. I know a lot of patients as they get older, especially women, develop hypothyroidism, but we want to monitor that, make sure it's not getting worse, okay? So nursing priorities and interventions, okay? So it's centered around supporting critical functions and gradually correcting the severe hypothyroid state. One priority is temperature management, as the patients are typically hypothermic. It's important to rewarm the patients gradually to avoid shock from sudden temperature changes. Blankets and warming devices can be used, but caution is taken to prevent overheating. Another priority is med administrations. Patients with myxedema coma often require IV levothyroxine, a synthetic form of thyroid hormone, to quickly increase the thyroid hormone levels and begin reversing the slowed metabolism. Oral medications are typically ineffective in this state, okay? So as gastrointestinal absorption is reduced because everything's low and slow, so giving oral meds is going to take forever. And is it even going to break down and get absorbed? No, so that's why we give it IV. Respiratory support is crucial for patients experiencing respiratory depression. It's kind of a give me. Oxygen supplementation may be sufficient for some people, but in more severe cases, patients might actually require mechanical ventilation to ensure adequate oxygenation and to support their breathing. They might just literally not have enough energy in their system to even breathe, okay? So now we're going to talk about the opposite of that is thyroid storm. And this can be scary in some patients. So thyroid storm is a life-threatening condition resulting from a sudden, massive release of thyroid hormone in the body, typically due to untreated or poorly managed hyperthyroidism. This excessive release of T3 and T4 hormones causes the body to enter a hypermetabolic state where metabolic processes accelerate uncontrollably. Severe precipitating factors can trigger a thyroid storm. These include infection, trauma, surgery, and severe emotional distress. Even procedures like thyroid surgery or stopping thyroid medications abruptly can precipitate a thyroid storm in patients with existing hyperthyroidism. So the signs and symptoms of a thyroid storm reflect the body's overdrive state. Okay, so basically opposite of what we just talked about with myxedema coma. Okay, so the signs include the patients are often going to come in with a high fever, sometimes even above 104 degrees Fahrenheit. They're going to be tachycardia. They're going to have hypertension. Neurologically, they may be agitated, restless, or even delirious. As the condition worsens, heart failure or shock may develop, making thyroid storm a medical emergency requiring immediate intervention. So as a nurse, you need to recognize these symptoms early so that we can intervene before it progresses. But untreated thyroid storm has a high mortality rate. So the treatment plan we're going to discuss on the next slide is aimed at rapidly controlling the metabolic crisis and stabilizing those vital signs. Okay, so the first goal is to stabilize the vital signs by controlling the heart rate and blood pressure. We're going to give meds like beta blockers, such as propranolol, and often we're also going to be giving things to like lower, back it up. Let's talk about propranolol. We're going to give that to lower the heart rate, and it's going to help us manage that tachycardia. Okay, so this is important because the heart is working in overdrive during that storm, and that's putting the patient at risk for heart failure. The next thing we're going to work on is the body temperature, okay? Because the high fever is associated with the thyroid storm. We need to be cooling this patient. So we're going to use things like cooling blankets, ice packs, acetaminophen to help reduce the fever. However, aspirin is avoided in these patients. We do not give these patients aspirin because it can actually increase free thyroid hormone levels in the blood, and we don't want to be adding more thyroid hormone to the blood that already has excess, right? Okay, so the next thing we're going to work on is blocking thyroid hormone production and release. So anti-thyroid medications such as an PTU, and it's propylthiouracil or methimazole, okay, are administered. You don't have to remember those meds. Just remember anti-thyroid meds that are anti-thyroid, are administered and they inhibit the production of thyroid hormones. Additionally, iodine preparations are sometimes used to block the release of stored thyroid hormones, but only after anti-thyroid drugs are given to prevent iodine from increasing hormone synthesis. Lastly, supportive care measures including managing the dehydration and the electrolyte imbalances, which can result from the fever and the tachycardia. We're going to be giving IV fluids, electrolyte replacement as needed, and that respiratory support if needed, okay? Okay, so care plan for a thyroid storm. We're going to be giving those meds. There's the med and spelled out right there. Anti-thyroid meds, beta blockers, corticosteroids. We're going to be suppressing things, okay, so that we can calm the body system down, right? We're going to be cooling them down, giving the hydration. You should be monitoring vital signs in a thyroid storm very frequently because these people are in overdrive. So every 15 to 30 minutes initially until you can get some more stabilization with the patient's vital signs. And then you can, expand that, how often you are monitoring their vital signs. You're also going to be educating your patient. They may be in crisis because they weren't the meds, there was a med issue or something like that. So you want to be educating the patient on medication adherence and also just what is going on and why they got to this point. So the goals, obviously, to control the hyperthyroidism, but we're going to be stabilizing the vital signs and supporting the respiratory function in the beginning so that it does not lead to heart failure and initially potentially high mortality. So, oh, it's the same slide. Sorry, I doubled the slide. Okay, so summary and key takeaways. You can pause the slide. This is just a little review over some of the things we talked about today, and that concludes Module 12. And this can be sometimes a hard concept. Hopefully you guys already kind of had some basics of diabetes and stuff, but like I said, go back and review basic med-surg content for diabetes and even some of the different other hormone and endocrine disorders, because that would help you understand these better. But otherwise, make sure you do your readings and the learning objectives before we talk about it in lecture.